Good afternoon, everyone. Thank you for having me among you. I already gained a new experience, made good friends, and I'm grateful for that. As some of you know about me, my name is Amr. Basically, I am from Egypt. I did my medical school there. I have had the opportunity to have ENT residency in my home country, Egypt, and I have ENT degree. Why I choose this topic of text media? Actually, it is so common. I know most of you are overwhelmed by most common health problem like diabetes, hypertension, heart disease, but I wanna in this presentation cover 3 points. Only 3 points. First, how we can do good ear examination, especially otoscopic examination. Second, when we start antibiotics and when we can wait and observe. And finally, what about over-the-counter medication like antihistaminic, cough medication, and topical like benzocaine and topical analgesic? Let's start with the first slide. Why otitis media is important topic? You know, in 1990 there is 25 million visits to clinic regarding otitis media. In 2000, this number came down, become less down, is become 20 million visits. These visits cost somewhere between 3 to 5 billions of dollars. There is 50,000 people worldwide dead from ear infection and its complication. And otitis media considered number one for children prescribed antibiotic. Number one cause for children to be prescribed antibiotic. You know, even mummies had ear problem. The researcher noticed that in mummies there is a destroyed mastoid without any visible trauma, most likely due to ear infection. You know, in also some years after that, in New York City, in Bellevue Hospital, they found that in 1932, 27 of admission in this hospital, it was due to otitis media. Let's start with the pathophysiology. As we can see in this video, there is a middle ear. This is the external auditory canal. This eustachian tube. Eustachian tube, it's a tunnel, it's a canal which connects the oropharynx, the pharynx, with the middle ear. This is the cause of most otitis media infection. There is a plaquage happen here in this eustachian tube, then is got fusion in middle ear, then got infected. What about pathogens? Most of the pathogens differ. This microbiology will bring all of these organisms. I would like to start with microbiology of otitis media has been documented by culture of the middle ear fluids. Culture of middle ear fluid by aspiration from these. They found that most of them bacteria and there is also virus. What is the most common organism? Is most of them is Streptococcus pneumoniae, and what is Haemophilus influenza. Now I have a question. Who can answer this question? What is the commonest bacteria causing sinusitis? What is the commonest bacteria causing sinusitis? Huh? Who can answer? I have a gift here. Yes, sir. Thank you, Dr. Lopez. Thank you, Dr. Shibli. Also, it's Streptococcus pneumoniae, then Haemophilus influenza, then Moraxella catarrh. That's why most family physician clinician should recommend pneumococcal vaccine and the Haemophilus influenza vaccine and the flu. These are three important vaccines. We can see that many of upper respiratory tract infection caused by Streptococcus pneumoniae and the Haemophilus influenza. I have another question. Who can answer? Who can help me? Why children affected more than adults? Yes, sir. Thank you. Thank you, Dr. Akram. Thank you, Dr. Abdul Qadir. That's number one. Thank you. Number one, eustachian tube. As we told in pathophysiology, that most of the infection due to eustachian tube. So in children, they have immature anatomy. They have a straight eustachian tube, as we can see in this, versus oblique one in the adult. They also have. So it is easy to get infection for infant than adult. Do you know another cause? Yes, adenoids. Most the kids up to 12 years have adenoids. You know, after 12 years, most of the adenoid atrophy. So most of the children after 12 years don't have any adenoid. See how adenoid in the oropharynx, how can affect the opening of eustachian tube. So it's affected the opening. So sometimes when the kids got infection to his oropharynx, and this are like an infected tissue, so it become more big, so can close eustachian tube, then he can easily get otitis media than kids. Also, they have less immunity, like immature immunity than the adult. So all of these three causes makes children more than adult. How we can diagnose otitis media? There is non-specific presentation, like a kid complaining from fever, vomiting, diarrhea, nausea, anorexia, irritability, and decreased appetite. And the specific causes, he comes pulling his ear due to otalgia, otorrhea, that you can see or the mom told you about, dizziness, and hearing loss. Now we start examination. Let's just go to one of the important slides. First, we have to inspect, palpate, then otoscopic examination. How we can, what we looking for in inspection? We're looking for a size, any swelling, any redness, especially behind the auricle, any discharge coming out, any scars of other operation, any trauma to his ear, because the patient complaining from ear pain. Most of the patient complaining from ear pain. So you have to check, maybe he had trauma. Then go to another. What about palpation? You have to move his auricle and ask him if he feels any pain, and to check any swelling, especially post-auricular, because many patients with otitis media, they can have also post-auricular swelling. We can say this later. Now, please, can I have your attention? Everyone here? Everyone can hear me? This is the important 2 slides. After this, you can sleep. It's okay. How we can do otoscopic examination? First of all, we have to hold the auricle. Please, don't do examination without holding the auricle. The external canal is oblique canal. You cannot see the tympanic membrane well if it's still like this. You have to pulling the auricle backward and upward for the adult, and backward downward for the kids. That's make it straight that you can see external canal wall and you can see the tympanic membrane, and you don't have to hurt the patient, because some patient from you cannot you persist to see the tympanic membrane and it's still it's oblique, so you push in, so it's not the good idea. The good idea is pull the auricle backward. What we're gonna see, we have to look not only for tympanic membrane but also for external auditory canal to check the color. The normal color is pink, so it's red. Does it have any wax, any problem, any secretion, discharge? And then you have to check the tympanic membrane. What we gonna see in tympanic membrane? The color, not on. We have to check 6 points in tympanic membrane. 6 points. Every tympanic membrane you have to check 6 items. 6 items. First, the color. The color should be gray. Not red like this. Let me tell you what is the normal one. Sorry. The above picture is normal tympanic membrane. It looks gray, not red, not yellow, not blue, not pink. It is gray. It have to be gray, and sometimes lessening gray. Gray. What? So first of all, it have to be gray. What? Not yellow like this. Then transparency. It should be transparent, so you can see structure behind. See, this is the handle of Méliès. This is some structure behind. This opaque, you cannot see any structure behind. This opaque, you cannot see any structure behind. Position, it have to be normal position, not bulging like this or retracted like this. See, this is the bone behind the tympanic membrane. It's almost attached to them, so it is retracted. Then the mobility. How we can examine mobility? See, the tympanic membrane, it have to be moved like this, not when you do examination, but after you ask the patient to do Valsalva maneuver. So you have to ask, what is it important? Yes, because if you cannot see effusion, if you cannot see fluid, but you can see limited mobility, the tympanic membrane will not move if you have fluid behind tympanic membrane. And the number 5, cone of light. Cone of light is actually reflection of light on tympanic membrane by the source of light. It have to be anterolateral, like this. This anterior, this upward, downward, medially, lateral. Sorry, anteromedial. I'm sorry, anteromedial. Anteromedial. Sorry, anterior. Posterior anterior. Anterior downward. Sorry, it have to be anterior and downward. So this downward and anterior. So can one tell me what this? Oh, okay, it's already. I'm sorry. It's left tympanic membrane, left ear. And finally, structure behind tympanic membrane. You are kidding me? Can I see structure behind tympanic membrane? Yes, you can. Yes, it's easy. So this is the handle of malleolus. This is the tympanic. Let me tell you. This is the ossicles actually. You can see the ossicles. This is what we call malleolus, stapes, ancus. So the malleolus is the big bone that attaches to the tympanic membrane. This is what we call short. This is the long process or handle. The short process or lateral process. Whatever you need. You can say it lateral process or short. You can say this long process